Hello, hello, hello. ECG Essentials returns with another episode. We have succeeded in our previous discussions in looking at the electrophysiological basis of ECG, the electrophysiological basis of ECG. We've also discussed in our previous sessions details of the ECG paper. We've had the opportunity to look at the electrodes and the leads that do the recording. We've also looked at the individual waves on the ECG in much detail. And we are almost close to the second session of our discussions, where we will be looking at various abnormalities that are commonly found on the ECG, and we'll be discussing these in under specific topics. So very soon in the part 2, as I'm talking about, we'll be discussing concepts like axis deviation. We'll be looking at arrhythmias, both supraventricular and ventricular arrhythmias. We'll also be looking at concepts like conduction blocks, AV blocks, bundle branch blocks. We'll be looking at hypertrophy of the ventricles, enlargement of the atria. We'll be discussing myocardial ischemia and infarction, pre-excitation and post-excitation syndromes. So we have a list of topics, specific abnormalities that we'll be delving into pretty soon. But as a transition to discussing these specific abnormalities, we want to look at a step-by-step approach that one may employ in interpreting an ECG. A step-by-step approach. This is necessary because we find that sometimes the ECG, when it's given to you, it's so scary, cumbersome, scary. You do not know where to start from. But if you were to have an approach, then at least we are able to make sense of some of the things we find. And secondly, this order, step-by-step approach should help us so that we do not miss some vital information thereon, right? So let's quickly start with these tests that I am talking about. And we start with looking at the biodata, verifying the biodata of the ECG that we are going to read, or the individual who we are going to, whose ECG we are going to read. And that comes with the name. It comes with verifying the age, verifying the sex of the individual. We also have to pay attention to the dates that the ECG was recorded. If necessary, we even have to look at the time, because there are times that we've had serial ECGs. Maybe somebody presented with some myocardial infarction, a STEMI, and serial ECGs may help us know how the process is evolving. And so sometimes we may want to look at the time that a particular ECG was recorded. Again, we need to be familiar with the clinical context, because ECGs will have to be interpreted on the basis of the clinical context. So we have to know why or who we are taking the ECG for. As I said, previous ECGs, if they are available, we have to go for them and then try to have an idea of what has been found before we delve into a new reading or a new interpretation. Pardon me. The other points that we need to confirm or to pay attention to will be the speed, the paper output speed, as we discussed in our earlier sessions. We mentioned that for the standard 12-lead ECG, we have a standard paper output speed of 25 millimeters per second. And also we did mention that although this is the usual standard, we are able to increase the speed or decrease the speed if need be. And so if you are reading the ECG, then you have to pay attention and be mindful of which speed that the paper is recorded at. And we have mentioned that this information is captured on the ECG paper, and if for any reason at all, that is the speed and the voltage, including the speed and the voltage, if for any reason at all we do not find them there, then the calibration marker that we find on the paper should be a guide in appreciating the voltage and the paper output feed. After we have verified the biodata of the individual, then we have to, the next thing we look at on the ECG is the rate at which the heart beats. And the normal, as we all know, is 60 to 100, 60 beats per minute to 100 beats per minute. And so bradycardia will be below 60, tachycardia will be beyond 100. Earlier, those who have followed us, we have discussed how to calculate the rate, the heart rate from the ECG. And then we mentioned that if the rate or the rhythm, the rhythm as we see on the ECG is regular, then the easier way or the easiest way to calculate the rate is dividing 300 by the number of large boxes between two QRS complexes. We came by this number 300 because of the standard paper output speed of 25 millimeters per second. What this means is that every second the ECG records 25 millimeters, and we have said that one large box on the ECG is 5 millimeters. So that means that every second the ECG should record on 5 large boxes. So the simple question is that if every second the ECG records on 5 large boxes, then in 60 seconds, that makes 1 minute within which the heart rate is often recorded. How many of these large boxes will the ECG have printed on? And that is simply by multiplying the 60 by the 5, arriving at the 300 large boxes. So if we go ahead and divide this number 300 by the number of large boxes or large squares between two consecutive QRS complexes, then we are able to arrive at the heart rate. And of course, this is used when the heart rate or the rhythm is regular. When the rhythm is regular, it suffices to say that because 300 large boxes is equal to 1,500 small squares or small boxes, then the same way we are able to divide 300 by the number of large boxes between two QRS peaks, then we are also able to divide 1,500 by the number of small boxes between two QRS consecutive QRS complexes. And of course, we expect to arrive at the same value. So in a nutshell, for a regular rhythm, that is how we can go about calculating the rate. If it is regular, choose 300 divided by the number of large boxes, or you can choose 1,500 and you divide it by the number of small squares or small boxes. However, if the rhythm is irregular, then we may not be able to easily use this method. Then we have to go ahead and use the rhythm, the R-wave method, the R-wave method. And in this method that we use for an irregular rhythm, we simply multiply the number of QRS complexes that we find on the rhythm strip. So the number of QRS complexes found on the rhythm strip, you multiply that number by 6. This is so because the rhythm strip, which is mostly lead 2, records for a longer period. That's usually records for a longer period as opposed to the other leads. And so if you were to look at lead 2, then usually lead 2 will record over a period of 10 seconds. So if we were to count the number of R peaks or QRS complexes on the rhythm strip and multiply, and that should be the number over 10 seconds. And if we were to multiply this by 6, then we arrive at an average number of QRS complexes or an average rate of the heart. So for an irregular rhythm, in a nutshell, look at the rhythm strip that is usually lead to recording over a period of 10 seconds, and go ahead and multiply the number of the RPs that you count by 6, arriving at the average heart rate. All right. So somebody may be asking, the ECG paper usually captures this information, in terms of the rate and then all other vital information. Why do I have to bother myself? Most often, the information we find on the ECG in terms of the heart rate is correct. And so one may not be very interested in what we have talked about. But there are a few times that the possibility arises where the rates may vary in terms of what the machine has provided, and this may be the case when, for example, we have very peaked T waves. Sometimes the machine may not be able to differentiate those peak tau waves from an actual QRS complex, and may end up counting some of them as QRS complexes. It's also possible that sometimes the QRS complexes may be too low in terms of voltage, and so the machine may not identify them as such, and so may be a little erroneous in its calculation. And so in such few instances, we may just want to double check, and to be sure that the rate that we are dealing with is actually what it's supposed to be. All right. A few times as well, still on the rate, a few times as well, we may be interested in calculating or determining the atrial rate separately from the ventricular rate. Most often what we are interested in is the ventricular rate, and that is what we have been talking about. But for example, when we have a complete heart block, where the atria are doing their own thing and the ventricles are also doing their own thing, in such instances, one may be interested in trying to identify the atrial rate separately from the ventricular rate. All right. So after verifying the biodata, we look at the rates, and in looking at the rates, these are some of the things that we should be interested in. So for the rates, you have looked at issues like bradycardia, and then you are thinking about possible causes. If there is a tachycardia, you are thinking about possible causes, or there also can be a bradytachy syndrome, where the heart beats fast at a point, slows down at a point, which may be the case in sex-sinus syndrome. And so these are some of the abnormalities that we still want to pay attention to when looking at the rate. With respect to the rhythm, that is the next thing that we are interested in. The rhythm is best analyzed using the rhythm strip, and I just mentioned earlier that most often the rhythm strip is lead 2, and that records over a longer period, so it helps us to be able to see some of the things that the shorter recordings probably wouldn't have provided. And it's in this same sense that more longer recordings like the Holters over 24 to 48 hours may even be more beneficial in providing more information on the rhythm. But for what we have, the standard, the rhythm strip should be where our focus will be during when we are trying to appreciate the rhythm. So for the rhythm, what are we looking for? We are trying to find out if the rhythm is regular or irregular. And if it is irregular, is it irregularly regular or irregularly irregular? And commonly, I'm sure most of our followers are familiar with the paper test that we may use to try to appreciate whether the rhythm is irregular. And in this case, all we do is that we can pick any sheet of paper, and then you place it on the ECG that you have. And then you identify a particular QRS or R peak, and then you mark a dot on the paper that you have placed right on top of the QRS peak or the R peak. And then you mark another dot on top of the next RP. And so you have now marked 2 dots on top of 2 consecutive QRS complexes. And then the next thing to do is just to slide this paper with the marks on top, with the dots on top, along the ECG paper. And of course, if it is a regular rhythm, we expect that these 2 dots that we have marked will fall on the consecutive QRS complexes as we move them along. So that is commonly what may help us, because sometimes you may think the rhythm is regular, but if you were to pay closer attention, you notice that there are some irregularities in there. After we have determined whether the rhythm is regular or irregular, the other interest with the rhythm will be the origin. So then where is the whole rhythm originating from? Is it coming from the sinoatrial node? Is it coming from the atria? Is it a junctional rhythm, or it is coming from the ventricles, right? And a few ways to be able to appreciate this origin will be to look at the P waves. So the first question is, are there P waves? Are there P waves? So if there are P waves, the P waves are present, then we have to look at the morphology of the P wave and the corresponding PR interval. So if you were to look at the morphology and the PR interval, then that will give you more information as to whether this rhythm is from the sinoatrial node or otherwise. So for example, if we are dealing with a sinus rhythm, so that means that rhythm is coming from the sinoatrial node before it is conducted along the conduction pathway, then usually we would expect that the resulting rhythm will be regular, will have a P wave that is of smooth contour, upright and round, and each of those P waves will be followed by a QRS complex. So when we are reading an ECG and we see such information, then outrightly we know that this is a sinus rhythm. However, if P waves were to appear abnormal, whether notched, inverted, peaked, any abnormality, and then we find that the rate or the rhythm is irregular, then it may then give us an idea that, of course, this rhythm is not coming from the sinoatrial node, but perhaps it's originating from the atria themselves, or it's a junctional rhythm. And then if P waves are absent totally, then we have other things that we may be thinking about. For example, atrial fibrillation or sinus arrest, of course, depending on what the other findings will show. So as we have just said, in looking at the rhythm, after we have tried to appreciate whether it's regular or irregular, the next thing of interest will be to find out if the P waves are present, and if they are present, how do they look like? The other thing that will help us appreciate the origin of the rhythm, is the morphology of the QRS complexes, the morphology. And in simple terms, we see that we have narrow complexes, and then we have wide QRS complexes. When we see that the QRS complexes are narrow, in the sense that they are less than the 110 milliseconds that is allowed, then we outrightly know that this will have to be a supraventricular event. So it may be from the sinus node, it can be from the atria, it can be a junctional rhythm. That is provided the QRS complex is narrow. If the QRS complex we find is not narrow but is broad, then most two things may explain. It's either the rhythm is of a ventricular origin, coming directly from the ventricles, or it is actually a supraventricular rhythm, but there has been an aberrant conduction during the channeling of that electrical activity. So if the morphology is, if the QRS is wide, then as we have just said, two things: is either it's ventricular or it is a supraventricular with an aberrant conduction. For example, an aberrant conduction may be seen in a number of bundle branch blocks, and so that may give us broad QRS complexes, but it doesn't necessarily mean that the origin of that rhythm is the ventricles. All right, so we have talked about the regular, irregular. We have discussed how to try to appreciate the origin of the rhythm. Then still around the rhythm, the other thing of interest is, are there ectopic beats? Are there ectopic beats? And these ectopics they are just beats that are arising from fibers outside the SA node, so because they arrive from specific areas that are not from the sinus node, they may be premature in their conductions. And so we may have examples like premature atrial complexes, premature junctional complexes, premature ventricular complexes, and these are all arising from ectopic beats or ectopic origins within the heart. Of course, because these are not coming from the sinoatrial node, we would expect that there will be some differences in terms of how the P waves will look like. That is, if we are talking about premature atrial contractions. And then, of course, if we are talking about premature ventricular contractions as well, we expect that the morphology of that particular premature complex will be different as compared to the normal QRS complexes, right? So look at the regularity of the rhythm, try to identify the origin of the rhythm, and then also be interested in whether or not there are ectopic beats. All right, so those are some of the few things that we want to pay attention to when we are looking at the rhythm on the ECG. So far, we've talked about verifying the biodata. We've looked at the rate and a few things of interest with the rates, and then we have just looked at the rhythm. And then some of the things that, of course, we need to pay attention to. The next thing that we are interested in will be the P waves. The P waves. And we have said over and over, the P wave represents atrial depolarization. And just a short while ago as well, we've tried to establish how important the presence or the absence of the P waves will be, even in trying to identify the origin of the rhythm, so that if the P waves are present and the morphology is normal, looks round, upright in the leads that is supposed to be upright in, with a normal PR interval, and then followed by QRS complexes, then as we have said, this rhythm is most likely a sinus rhythm, And in looking at the P waves as well, if the P waves are absent, then we have said that a few things will be possible. For example, atrial fibrillation, sinus arrest, or sometimes you can even have atrial flutter, So when the P waves are absent and we see fibrillatory waves in terms of the isoelectric line now showing as fibrillatory waves, and the rhythm is irregular, then of course that will be a pointer to atrial fibrillation. If P waves are absent, but we see a sawtooth pattern, then that may be a pointer to atrial flutter, and of course a flat line with absence of P waves will be a pointer to a sinus arrest. All right, so a few things about the P waves helps us to appreciate the rhythm, that is the origin of the rhythm, and then also gives us an idea, if they are absent, a few possible causes of the absent P waves. We have mentioned that earlier in our earlier discussions that the amplitude of the P wave usually does not exceed 0.25 millivolts in terms of the voltage, it does not usually exceed 0.25 millivolt. We said that the atria themselves are quite small, so they are not able to generate substantial amount of electrical activity that will be recorded. Even smaller in the precordial leads. The P waves usually are even smaller in the precordial leads, so that they are usually even less than 0.15 millivolts in the precordial leads. But regardless, the lead we are talking about, they usually do not exceed 0.25 millivolts in terms of amplitude. The duration also usually does not exceed 3 small boxes. So that means it does not go beyond 0.12 milliseconds. And because the overall axis of the P wave usually lies between 0 and 75 degrees, we expect that in the inferior leads, particularly in lead 2, which is around 60 degrees in terms of its angle of orientation, and then the other left-sided leads, we expect that we have upright P waves. And for AVR, which lies far off around -150, then we expect that the P waves will be inverted in that particular lead. Generally, the first half of the P wave is considered to represent the right atrial activity or right atrial depolarization, whereas the second portion, if we were to divide the P wave as we see into two, then the second portion will rightfully represent left atrial depolarization. And so in V1 that we have said that usually we expect to have a biphasic P wave clearly defined usually. Then if we are looking for any abnormality, peculiar abnormality to the left or to the right, then the lead of interest should be V1, because it is in V1 that we usually have a biphasic and well-defined separation of the individual components. But in most of the leads, the P wave will remain upright, except of course AVR and sometimes, except of course AVR. All right. So in looking at the P waves, apart from the few things that we have mentioned earlier, other things of interest will be whether there is a P wave enlargement, right or left atrial enlargement, So whether there's P pulmonale or mitrally, We are also interested in P wave inversions, which may be the case in atrial or junctional ectopic rhythms. We mentioned earlier that because these are not coming from the sinoatrial node, we do not expect that the P waves will look like those coming from the sinoatrial node. So if we were to see some of these inversions in the context of ectopic beats, then it gives us an idea of what is going on. And then also pay attention to some variable morphology of the P wave. The P waves on a particular ECG may look totally different from each other. One will look different from the next, and the next will look and that may be the case in conditions like multifocal atrial rhythms. All right. So as we have just said, look out for atrial enlargements, whether right or left. Look out for abnormalities like the P wave inversions that may be pointers to ectopic beats. And of course, if there is any other variable morphology that may help point to multifocal atrial rhythms. Having appreciated your P wave, then we are now moving to the PR interval. So for the PR interval, of course, that has within it the PR segments. It is the period from the start of atrial depolarization to the start of ventricular depolarization, and that duration is usually between 0.12 to 0.2 seconds. So that is between 3 to 5 small boxes, 3 to 5 small boxes. So beyond 0.2 seconds, we say it is prolonged, and less than 0.12, that's less than 3 small boxes, we say it is shortened. The usual causes of a prolonged PR interval, usually we find that in AV delay. So for example, when we have first degree heart block, for instance, where we expect that a PR interval will just be prolonged, and that we also see this prolonged PR interval in second degree heart block, morbus type 1, that is the Wenckebach phenomenon, where we realize that there is a gradual increase in the PR interval from beat to beat until eventually there is a drop beat. So commonly we find that a PR interval will be prolonged in situations where we have AV delay. If it is shortened, however, one explanation may be that the origin of the whole rhythm is, the sinoatrial node as an anatomic variation is close to the AV node, and so the conduction time is shorter. Besides this normal anatomic variation, the other possibility is that there may be accessory pathways. Those are faster shortcuts, through which the impulse is conducted. So for example, in a pre-excitation syndrome like Wolff-Parkinson-White, we find that the PR interval is shortened, and that is not because of an anatomic variation, a normal variation, but because there are accessory pathways through which the impulse is conducted. We will look more at Wolff-Parkinson-White and other pre-excitation syndromes as we move along with our discussion. All right. So although usually our interest is in the PR interval, whether it's prolonged or it is shortened, another interesting thing we need to pay attention to is the PR segment, whether it is elevated or depressed. So for example, in a situation like acute pericarditis, in the early stages where we expect that we will have widespread saddle shape ST elevations in most leads, we also expect that we will find the PR segment depressions together with these ST elevations that we commonly talk about. So in acute pericarditis, PR segment depression is a very significant finding, right? The other interesting thing about PR segment elevation or depression is with people who have myocardial infarction. The teaching is that usually in such individuals, when we have maybe such individual with a STEMI, we clearly see a STEMI. If we were to find an associated PR segment depression or elevation, it suggests a concomitant atrial ischemia or infarction that actually has been shown to have a poor prognosis, right? So in reading our STEMIs and all our MR ECGs, it is important that we look out for the PR segments, whether it is normal or depressed or elevated. Of course, cardiologists will talk about like the Lewis criteria in trying to identify atrial ischemia or infarction, if I may say. That is a whole cumbersome process, but all we want to establish here is that when we see a PR segment depression or an elevation, particularly in the context of somebody who has an MI, it should be important for us to think about the possibility of an associated atrial ischemia.